All right. Welcome to this webinar. This is titled USPHS 101 for Industry. My name is John McElligott, the Deputy of COA and COF. COA is the Commissioned Officers Association of the U.S. Public Health Service. It's a sister organization of the PHS Commissioned Officers Foundation for the Advancement of Public Health. Many of you on the line are maybe more familiar with COF, which puts on the annual USPHS Symposium. The USPHS Scientific and Training Symposium is going on to its 54th year, an annual conference for men and women of the U.S. Public Health Service who work throughout federal agencies, providing clinical care, non-clinical administrative services to the federal government and patients around the world, in fact. Today's presentation, we have two speakers, Captain Dana Thomas and Commander Heather Brake. Both have very important roles, not only for the Commission Corps, but also for our Association for COA. And so at this point, I want to turn it over to Commander Brake. She and Captain Thomas will provide some information about an overview of the U.S. Public Health Service Commission Corps, the agencies where officers work, what they're doing, and why it matters to you as members of industry. Commander Heather Brake, please go for it.
Thank you. Thank you so much, John. And thank you to everyone who's attending the seminar today. I can't tell you what an honor it is for both Captain Thomas and I to be able to spend some time with you this afternoon describing what our service is and how we can potentially work together. So the purpose of our seminar today is really for members of the industry to so you can get a sense of what our service is and what we do. As John mentioned, today I will be presenting as well as Captain Dana Thomas, and we thank John and the Commissioned Officers Association for putting this together. The very first thing that I'm going to do is turn it over to Dana to introduce herself so you can get a sense of what her role is within CDC and the association, and then I will take over for a bit from there. So Dana?
Great. Good morning or good afternoon, everyone, depending on where you are. My name is Dana Thomas, and I currently work for the Centers for Disease Control in their Center for Preparedness and Response at the Division of State and Local Readiness, which means that my work is actually outside of Atlanta. The last couple of years I've been in New Jersey in the Department of Health. I'm the Medical Director for Emergency Preparedness for that state, for our state of New Jersey. And prior to that, I was in Puerto Rico for 5 years. Previous work I've done, I did a fellowship with the CDC called the Epidemic Intelligence Service. Prior to that, I spent 7 years in the United States Coast Guard practicing occupational and environmental medicine, and in the U.S. Army for 7 years prior to that, doing aerospace and operational medicine. So my storied work with the Commissioned Officers Association began shortly after I joined the PHS with the Coast Guard. I became the Physician Category Day Chair, and I did that for 9 years. And in the last year, I became a Board of Directors member as a field representative, since all of my work with the PHS has really been in the field outside of Atlanta or one of the headquarters cities like DC. Thank you. Look forward to getting to know you guys today as well.
All right, thank you so much, Captain Thomas. So as John mentioned before, my name is Commander Heather Vera Brake. I am actually a veterinarian, but I'm serving as the Director for Communications for the National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry. So for those of you who may not be aware that ATSDR, or the Agency for Toxic Substances and Disease Registry, is actually one of the agencies that's currently under furlough right now. So before I became the Director for Communications for Environmental Health and Toxic Substances, I worked in the National Center for Emerging and Zoonotic Infectious Diseases as a quarantine communications lead. So I was one of the communications leads during the Ebola response. And at that time, our group at CDC was responsible for all the border screening as travelers were coming from the impacted region into the United States. I also at one point was the director of the non-human primate import program at CDC, and as a veterinarian that meant that I had oversight over all the monkeys that were coming in for research or for exhibit like zoos and circuses and things like that. I worked in Travelers Health, and then I had actually started my career here at CDC in the Division of Food, Water, and Mycotic Diseases branch, working on foodborne illnesses and working with outbreaks like the spinach outbreak that happened in 2006 and the outbreak with peanut butter, and Taco Bell as well. For the Commissioned Officers Association, I too have been involved with the veterinary category and with the Commissioned Officers Association for quite a bit. I've been on the board of directors as a veterinary director since 2013, and this year I'm currently serving as chair of the Commissioned Officers Association. So the agenda today for our talk, our time together, is I want to give a history of the Public Health Service, and we'll just spend a few moments on there because I want to give you a sense of why we're dressed the way we are and why we do the things we do. And then from there, Dana's really going to lead you into what our mission and organization is. We're going to talk about the professional categories of the Public Health Service and give you a little bit of overview of what they do. Also talk about all the different agencies where public health officers work and our role. And then we want to spend a few moments at the end really addressing some of the questions that you and industry might have for us as officers. So a high-level overview, and we'll dive into this a little bit deeper during this presentation, but our Corps is more than 6,200 full-time, highly qualified public health professionals. We're an all-officer Corps, which means we do not have enlisted people. We all have qualifying medical or service degrees that qualify for public health. And we serve on the front lines in the nation's fight against disease and poor health conditions. And we're going to talk a little bit about that as we talk through the history, and then Dana will expand on that in her comments. So in order to really understand the origins of our service, the uniforms we wear, the colors we have, it's really important to talk about our early history, which includes trade and travel around the world. And so, as you know, for hundreds and thousands of years, goods were moved from country to country via the sea, and ships would travel all over the world bringing any manner of goods and actually diseases with them. And some of the diseases we saw were smallpox, cholera, yellow fever, actually chickenpox, which the technical name is varicella, and tuberculosis. And you would be surprised that actually in quarantine, some of the diseases we still worry about today are cholera and tuberculosis and chickenpox. So when the United States was first established, little was done to prevent the importation of infectious diseases, and protection against imported diseases really fell under the local and state jurisdictions, which meant that when sailors came in from these ships who were sick, the local doctors and hospitals would have to pay for and take care of them. So as you can imagine, it got to be quite expensive. So on this slide here, I have this cartoon that was drawn hundreds of years ago, this image of the skeleton, which really was to signify that cholera was coming to shore. And then the next picture I have is a ship with a yellow flag on it, and that meant that the ship was put into quarantine off the coast of a port. And at that time, ships would have to sit at port for 40 days with the yellow flag showing that they were under quarantine until they could be cleared by eventually public health service officers to come into port. So moving on, as I mentioned before, it was really expensive for the states to have to take care of all of these sick seamen as they were coming ashore. So in 1798, the president at that time, John Adams, signed a Relief of Sick and Disabled Seamen Act. And this meant that for every sailor that was coming on a vessel, the captain of the ship would have to pay 20 cents per month for each sailor. And if they didn't pay that, then their license to come ashore would basically be revoked. But that 20 cents per month for a sailor was used to help pay for their care in the existing hospitals. And then any additional funds that they weren't used to care for those seamen were used to build new hospitals at the ports of entry and pay for staff and directors of the hospitals. And so the next image you have here is a quarantine marine hospital. And so in 1799, Congress extended the act to cover every officer and sailor in the U.S. Navy, leading to the creation of a network of these marine hospitals along major waterways. And so this was not only along the sea coast of the United States, but also along in the Great Lakes as well. So in 1870, the Marine Hospital Service Administration was centralized with its headquarters in Washington, D.C., and the president appointed a supervising surgeon, which is later called our Surgeon General. And so on the next slide here, you see this picture of John Maynard Woodworth. He was the first supervising surgeon, or our first Surgeon General, and he decided that he was going to adopt a military model for these hospitals. And so he instituted examinations for everyone who wanted to apply to be a doctor or a nurse in these hospitals. He put the physicians in uniforms, which you can see. He created a cadre of mobile career service physicians who could be assigned to various Marine hospitals as they were needed. In 1878, Congress enacted a National Quarantine Act to prevent the introduction of contagious infectious diseases into the U.S. We still have quarantine today. CDC runs a quarantine service, and it is also run with quite a few public health service officers at our ports of entry. And then the Marine Hospital Service at the time was tasked to administer immunization programs in the control epidemic diseases, particularly as they were coming in to ships. And so you see on this slide, I also have an image of our seal, and you may notice that there's a chain around the anchor, and so this is called a fouled anchor, and it's supposed to represent sick or illness among sailors coming ashore. So in 1912, the Public Health and Marine Hospital Service was shortened to the Public Health Service, and their powers were brought in by Congress, which authorized them to do investigations into human diseases, sanitation, water supplies, and sewage disposal. And then in the 30s, the Commission Corps was expanded to include engineers, dentists, research scientists, nurses, veterinarians, and other healthcare specialists. So today, we are a corps that prevents and eradicates disease, and one that provides direct patient care to vulnerable and underserved populations. We also do research, epidemiology, and we advance public health. So with that, I'm going to turn it over to Dana, who's going to talk to you more about our service as compared to other services and delve deeper into what our service is made up of today.
Thank you so much, Heather. So I just wanted to do a quick civics lesson as an overview. In the United States, we have 7 uniformed services. We operate under 4 distinct departments. So 4 of the 5 armed services reside within the Department of Defense, and those are the ones people most frequently identify as, the DoD, the Army, the Navy, Marines, and Air Force. But the Coast Guard, of course, is the 5th Armed Service, previously under the Department of Transportation, but currently lives within the Department of Homeland Security, which merged 22 federal agencies in November of 2002. Another department that is represented besides the Defense and Homeland Security is the United States Public Health Service, falling under the Department of Health and Human Services. And then, of course, we have the National Oceanic and Atmospheric Administration. They have a commission corps as well, which lives within the Department of Commerce. So each of these services have dual personnel systems comprised of civil servants and active duty personnel. The U.S. Public Health Service has approximately 60,000 employees, of which about 10% are active duty commissioned corps officers. So PHS officers really serve as a flexible, value-added human capital asset that augments federal operating divisions, often in positions that are difficult to fill and require public health expertise. So we'll learn a little bit more next. The chain of command in the United States Public Health Service, basically, we fall directly under the Office of the Surgeon General, who's the 3-star Vice Admiral Jerome Adams. Above him is the Assistant Secretary of Health, and that is a 4-star Admiral, Admiral Brett Giroir. He, in turn, reports to the Secretary of Health and Human Services, Alex Azar, Secretary Azar, and that person is appointed, of course, by the President, who is also our Commander-in-Chief. As Heather mentioned, again, our PHS mission is very distinct. To protect, promote, and advance the health and safety of our nation. PHS officers fill essential public health leadership and service roles within the nation's federal government agencies and programs. This extends to work overseas and within tribes and territories, state and local governments, where we often build capabilities and capacities to further our national and global health security efforts. So public health service officers dedicate our lives to public health promotion, disease prevention, and advancing public health science. I wanted to mention what the core values are for the PHS. They are leadership, service, integrity, and excellence. PHS officers provide urgently needed public health and clinical expertise in response to large-scale local, regional, and national public health emergencies and disasters. We work with other nations and international agencies to address global health challenges, and we conduct and support cutting-edge research for the prevention, treatment, and elimination of disease, health disparities, and injury. So I know before we discuss even the categories, you may be asking yourself, well, what would it take for me to become a PHS officer? What are the requirements for being a PHS officer? The first thing I would say is you need to be a U.S. citizen, less than 44 years old, and you must be medically qualified. We have a physical fitness test that's done annually, and we have height and weight restrictions. And it's really, a lot of it has to do with no chronic illnesses that would prevent you from being in a fully deployable state. You also must have an unrestricted professional license, if applicable, and a qualifying degree, which is what determines the officer's category. So as you see, we have 201 dental officers, we have 94 dietitian officers, 394 engineering officers, of which I'll say that this includes chemical, electrical, mechanical, civil, biomedical, computer, and environmental engineers within the PHS. We have 346 environmental health officers, and if you think about what they do, they have both domestic and international roles, including disease prevention, radiological health, industrial hygiene, food safety, injury prevention, and emergency preparedness, epidemiological surveillance. So during natural disasters, of course, environmental health officers really become paramount to protecting the public from environmental threats and communities helping them to recover. I think the most diverse of all of our categories are the health services officers. So this category represents biological, physical, environmental, and social sciences. You have optometrists, social workers, podiatrists, physician assistants, medical technologists. We have health educators within health science service officers, but they also serve as the healthcare administrators. They manage healthcare information and medical record systems. Health services officers really oversee administration, acquisition, budgeting responsibilities, and they shape, I would say, the healthcare regulatory and policy initiatives often within the facilities they work. Next, we have medical officers like myself. So we serve on the front lines of public health, of course, and we do a lot to develop, I would say, standards of care and practice. Our work at NIH and CDC. The nurse officers, I think, perform a lot of inpatient and outpatient clinical services. They're among some of the nation's most underserved areas they work in. They also, of course, can conduct clinical research, review drugs, look at the impact of health policy, and they gain clinical leadership while developing professional skills. Now, pharmacy officers, of which you might see there's 1,316, they are another large category. Those in the nurse officers are two largest. They work throughout the Department of both Health and Human Services and in other federal agencies. They often sit on the pharmaceuticals and therapeutics committees. They work to approve and monitor new drugs, conduct research. So PHS pharmacists, I would say, experience much greater work variety than in most pharmacy practice settings. We have scientist officers who conduct cutting-edge research, therapy officers, including occupational, physical therapy, speech and language pathology. Sometimes these therapists are also involved in mental health after disasters. And lastly, Commander Vera Brake's category, veterinary officers. And you heard a good example when you look at her career of the many things that she's been involved in. I like to think of veterinarians also as being the center of the One Health model, which is really required to manage diseases like Ebola, influenza, rabies, and Lyme disease, which have both human and animal consequences. I'll mention next the primary federal agencies with which federal PHS officers work, because we are really assigned to 9 of the 15 U.S. departments, and we are located in over 800 locations worldwide. The 4 largest departments that host PHS officers are, of course, Health and Human Services, and we are in all 10 of their operating divisions. The Department of Justice, because we work extensively in the Federal Bureau of Prisons, the Department of Homeland Security, and the Department of Defense. And just so you can visualize, where are we? I mean, this is the regions of Health and Human Services. Corps officers are stationed in nearly every community in the United States, including those underserved, isolated, hard to fill, even potentially dangerous assignments. The Corps has the ability to connect the current administration's programs, like from the ASH and the Surgeon General's initiatives, with the community as visible, uniformed, nonpartisan, unarmed public health assets. And this is unique among all services and government assets. More than half of the United States Public Health Service officers work in jobs above their grade, which actually provides considerable cost savings to their employers. We are on active duty 24/7. We're a fully deployable force. For example, if the government shuts down, like Heather's agency is not being paid right now, we work. If there's pandemic influenza or natural disaster, we provide key continuity of operations for the health of our country. And I wanted to give you a little bit more granularity when we say that we're in a lot of different departments, a lot of federal agencies and programs. This can be a bit of a governmental alphabet soup, but I just want to show you, by agency and by PHS number count at this moment in time. Again, we're talking about almost 6,300 officers, 6,289 officers in agencies as diverse as Children and Families, Healthcare Research and Quality, Commander Brake's agency, Agency for Toxic Substances and Disease Registries. We talked about Bureau of Prisons, a lot of officers at CDC, a couple hundred within the Centers for Medicaid and Medicare Services. Homeland Security, of course, we're with the Coast Guard. We are the physicians and the dentists and the environmental health officers for the Coast Guard. And we work within the Division of Immigration Health Services, within the Department of Commerce. We, aside from the Commission Corps that NOAA has, we also serve a role within NOAA. We work for the Department of Defense in TRICARE management activities, and also we have a huge role in a psychological care for returning wounded warriors. EPA, the Environmental Protection Agency, the Food and Drug Administration, of course. I think Department of Interior, we work in the Park Services. Another large employer, Indian Health Services. We work with other jobs within the Department of Justice. We have, almost 300 officers within the National Institute of Health. Our own Secretary's office, of course, we have some personnel. We work a lot with the Substance Abuse and Mental Health Services Administration, which is key in our opioid response right now in our national epidemic. So we expect, we do work with USDA, Department of Agriculture, and we're expecting more officers. We just signed a new memorandum of understanding with the VA to bring on more officers in the coming years to assist with their needs. So I love the phrase, we're America's health responders. I work a lot with first response in New Jersey, and there's no more noble I think title than to be called a actual responder, because it means that we're at your beck and call for the country. We're adaptable, we're mobile, we're deployable. We're an active duty force that's ready to meet public health needs and demands. We're unique facilitators and representatives of this country's national health priorities, whether we're practicing it within the U.S. or practicing overseas. And this is a list of some things we've done recently, but I will say that more than 1,400 Commission Corps officers responded to Hurricanes Harvey, Irma, and Maria in 2017. We were honored with the DoD Humanitarian Service Medal for those of us that participated in that. With respect to Ebola, again, in the thousands of officers responded to the Ebola crisis. And we, as a service, received the Presidential Unit Citation. For the Zika response, I served as the Chief of Staff in Puerto Rico, where we hosted 500, both civilian and officers, down doing governmental service, working with the Puerto Rico Department of Health to help us mitigate that medical crisis at the nexus of where, I mean, really the epicenter, I should say, of where it was happening in the United States. So with that, we don't know what tomorrow's health crisis will be, but we do know that the United States Public Health Service will be there and ready to serve. With that, John, I'll turn it over to you.
Thank you very much. Thank you to Captain Dana Thomas and Commander Heather Brake for your presentation. So as they mentioned, the Commissioned Corps of the U.S. Public Health Service is celebrating 130 years as a uniformed service, going back to 1889. That's quite a long time. The Air Force doesn't have that long of a history. Many other services do not. And so why does it matter to you, members of industry? For several reasons. There is no federal health issue that does not have a PHS officer somewhere in that system, somewhere in that feedback loop, the development of policies, the approval of drugs, the review of devices that you sell, the products and services that members of industry sell to the American public, sell to federal agencies. There's always a PHS officer somewhere in that system. So we'll get to some questions. I wanted to mention the USPHS Symposium. So this is an annual conference provided, sponsored, produced by the PHS Commissioned Officers Foundation. Annual conference for men and women of the Commissioned Corps to get together. They talk about what's happening across the uniformed service. They talk about what's happening in the veterinary profession, what's happening in the medical profession for physicians, same thing for nurses, same thing for engineers. We also get attendees from sister services, other federal civilian employees, and because it moves around every year, we get state, local, tribal health organizations and health professionals attending as well. And so the 54th annual conference will be in Minneapolis, Minnesota, the week of May 6th through 9th. And so we expect to get attendees from the local Twin Cities area, also from the state and the tribal, the federally recognized tribes that are in Minnesota in that region of the country. So it's a great opportunity for you as members of industry to connect with federal health executives and to, you know, touch hands with, ask questions with the folks who are key officials for the policies and purchasing decisions that affect your companies. Next slide. Okay, so what I want to do is ask you to type any questions in the chat area of GoToMeeting. So go ahead and type those questions in now. And while we're waiting for any questions to come in, I wanted to start by asking Captain Thomas and Commander Brake a couple questions that we've already identified from members of industry in the past. So I wanted to ask you, you've got a lot of different federal agencies, departments where you work. How many patients, for example, are being tracked by CMS, Centers for Medicare and Medicaid Services?
John, let me take that one. I know that in 2016, that there were 57 million Medicare beneficiaries that were either aged or disabled, and another almost 71 million that were Medicaid beneficiaries. So that's a lot of patients that fall under those two programs, Medicare and Medicaid.
Okay. And then another big one where you have a lot of PHS officers assigned to work is the Indian Health Service. How many patients have access to those IHS facilities as members of federally recognized tribes?
Well, there's over 500 tribes, and I know that there's 2.2 million American Indians and Alaska Natives that are able to access the 170 IHS and tribally managed direct care units. In I think it was 2016 also, the inpatient count was over 39,000 inpatient visits, and outpatient visits topped 13 million, so closer to 14 million. I think the IHS budget appropriation for 2016 was close to $5 billion.
Okay. Another big one for clinical care is the Federal Bureau of Prisons. Do you have any sense of the scope of how many patients, for example, are in BOP?
I do. I contacted one of our colleagues, Captain Sylvia Cohen, who works with the BOP, and she confirmed that there are close to 180,000 inmates that are cared for within the 119 facilities that they have. Now, as some of you may know, a few of the Bureau of Prisons facilities have been privatized, but 85% of the facilities are still federally mandated, federally run. And BOP, on top of the almost 200,000 inmates they care for, has the responsibility for the health and well-being of 38,000 employees that are the corrections workers.
Okay. So you had mentioned before that PHS officers, especially pharmacists, for example, are deeply involved with formulary and purchasing policies for drugs. We talk about purchasing federal agencies and officers' roles in that system. What are examples that you could talk about for purchasing of medicine, surgical supplies, clinical supplies, or other devices?
Well, Heather, do you want to give the example of the clinic at CDC? I mean, that's a very good occupational health clinic. Great example.
Yeah, so it's going to kind of get to your answer in a roundabout way with a couple different examples. But John, some examples of how we purchase things is like our officers, for example, that there's an officer, Captain Susan Lippold, who runs all of the clinics at CDC, multiple occupational health clinics. And so servicing up to, about 15,000 employees. And so she would be responsible for ordering supplies, just like as the Captain Thomas mentioned, the person who is running the clinics in BOP and I do not know for sure, but I assume that there's similar clinics for all the other federal agencies. But another example of how officers are selecting and making decisions about purchasing supplies is during emergency response. And so I was able to participate in the 2017 hurricane response in Puerto Rico and Virgin Islands, and a large amount of money was spent on vaccinations and other type of laboratory supplies, clinical supplies to help both Puerto Rico and USVI help them recover and meet the needs of their populations while their other health systems were down. So a lot of that went through, purchasing went through the CDC Foundation, but those type of decisions are being made in an emergency situation and also in the day-to-day jobs of our officers.
Okay, thank you. There's a question that came in from one of our attendees, and they thank you for the detailed presentation. Person writes that there seems to be a disconnect between what we're talking about now, collaboration between industry and federal agencies, with what is coming out of individual medical centers of the VA system. And so asking whether we could talk about examples of collaboration that's happening between federal agencies and members of industry. Great question. The VA medical systems, those are under the VA, separate department than Health and Human Services. As Captain Thomas and Commander Brake had mentioned, there's currently one officer, a liaison officer, detailed to VA to expand the agreement to place physicians and nurses and a few other PHS officers in VA's clinics and hospitals to provide direct care or manage those patients. So the Public Health Service does not run the VA system. That is the VA, quite a separate department. But Captain Thomas or Commander Brake, any examples you could talk about between collaboration of industry and federal agencies where officers are working?
Absolutely.
Heather. Yeah.
So I'll take over first, and then my perspective is through the veterinary organizations. But we frequently work with industry to help advance public health. So I think of industry as being not only, they're kind of like our conduit and they're very close partners. So one of the things I did as a veterinary officer in my previous job is set up a network of not only pet stores, but veterinary associations across the country. And we would work to get out information and talk about certain type of testing and other things that people would need to know in order to keep themselves safe around animals. And so that's just one example, but during emergency response, we use a lot of contract companies to get things done. We use the Postal Service, we use whatever it might be, we use the vaccine companies, we use the company that made off. We partnered with all of these groups in order to meet the needs of the population we were serving. So, for example, Puerto Rico had a big problem with vector control, so we worked with the makers of OFF to be able to provide some supplies for them so that they could keep mosquitoes away. Let's turn over to Dana for other examples.
But, I was just thinking, like, as in the civilian sector, I mean, PHS officers work in a variety of jobs where they would either they make recommendations for, or they directly are the purchasers of supplies or devices or information systems, provided that they have no conflict of interest. I mean, that's just the key thing with working within the federal government. I can't be purchasing a product that my spouse sells. That's just, I have to, my organization has to be, there has to be no conflict of interest, but it provided that the vendors and the industry partners aren't related to the PHS officers, then I think that there should be no problem. And even with PHS officers, even if I'm not the person that normally purchases something for my agency, I know who the person is. We tend to work in positions of leadership. That's what we're paid to go into organizations to do. And I would just say that whether we're talking about within the Bureau of Prison, or a tribal or an Indian Health Service run clinic, or an asset that the Coast Guard owns, if there was something being sold that was needed, the person that you're dealing with from the PHS knows the person who does that kind of purchasing. So it's just a question, I think, of what industry has to offer that we are not using as of today. Or maybe we have
that's a great point. Yeah, and we offer COA and COF, especially through the USPHS Symposium, that if there's not an officer on the floor who is the right person, we can find somebody in the system who's the right point of contact to assist them. The FDA works very closely hand in glove with members of industry to review devices and medicines in the approval process. There's a question that came in from another attendee. Can you differentiate between BOP and DOC? I think the question is referring to Department of Corrections. And my understanding is Department of Corrections is typically a term that relates to state or local correctional facilities. BOP is at the federal level, which is under Department of Justice.
That's correct. So, I mean, I do a lot of work in New Jersey with our partners in Department of Corrections right now, looking at Suboxone and trying to mitigate the problem with drug overdoses with patients leaving our state facilities, our prisons and jails here in the state. But DOC in that format that's mentioned is Department of Commerce. So, but like I said, we have a lot of officers like myself that work at the state level that are more involved with the not just at the high federal agency practice of medicine or healthcare administration, but are observant and aware of what the states need.
Yeah. So this may be the final question because we've gone a little over time. Can you provide details on the relationship between PHS, Indian Health Service, and individual tribal nations? I know neither of you are currently detailed to Indian Health Service, and there is a relationship between each of these federal tribes, the 500 some odd that you talked about, Commander Thomas, and whether it's a compacting or contracting relationship with the federal government. Could you provide any more details about those relationships?
Well, I do know that PHS officers work at both types of clinics, both or types of healthcare, direct healthcare servicing units. So they work in IHS run clinics, and also within the tribally run clinics, PHS officers are certainly hired to work in both. I think that what happens is it depends on with your contract. For example, and Heather and I both work for like CDC, in a sense, ATSDR, of course, more specifically for Commander Brake. But with my particular employment, it actually goes through the state of New Jersey. So the state of New Jersey says, I'm looking for a Dana Thomas. I'm looking for someone that has a background and experience in emergency preparedness that can provide medical leadership. So the state funds me. In other words, the state, I'm part of, my salary's cut right off the top of a grant that CDC gives them, because they know they could not buy a person on a state salary that can perform the activities or duties that I do. So they say, well, you know what, but we need someone that does that. So they fund me. My salary is funded through CDC, but it's actually through the U.S. Public Health Service, of course. but the money comes back from the state, essentially stays in the grant, and then CDC pays for me. So I think that very similarly, the IHS, if they have someone that they're interested in, the PHS officer, they're paying the PHS officer's salary on the back end. And they're committing at that time, whether it's a 2-year contract or 4-year contract, to whatever length of time that they feel that they would need, or that both parties can agree to. Does that clarify it?
I think that helps, yeah. And I'll note for every member of industry, everyone attending, listening to this, many of the senior leaders in the Indian Health Service are PHS officers, and the vast majority of them are also members of federally recognized tribes, because there's hiring preference for federal civilians to be members of those tribes that they're serving. Same thing for PHS officers. So officers who are helping to lead that system and work in the system at the lowest levels to the highest levels as acting director, for example, are coming from federally recognized tribes, caring for their families and friends. And we can help to connect you with the right people. So at this point, I want to turn it off and thank everyone for attending today's presentation. I want to thank Captain Dana Thomas and Commander Heather Brake for providing some amazing remarks and our USPHS 101 for industry. We look forward to answering any questions that members of industry have, especially if we can see you in person at the next USPHS Symposium. Thank you very much.
Thank you, John. Bye.
Thank you.